The next talk is by Professor Jahr. This is Professor Jonathan Jahr is now Emeritus Professor of Anesthesiology in UCLA. After medical degree, he was trained in anesthesiology, followed by pediatric anesthesiology, then cardiovascular and thoracic anesthesiology. He raised from assistant professor to associate professor, and then joined UCLA as professor of clinical anesthesiology from step 1, 3 years, to step 2, 3, to 4, to 5, to 6 years. He was principal investigator, as most of you know who are here, for clinical trials on blood substitute in 3 groups: Hemo-Sol, BioPure, Alias. He's also consultant of 5 blood substitute companies. So I thought he's well qualified to give this overview lecture of the present status of the product from BioPure. Professor Jahr.
Bonjour. Comment ça va? Bien? Bien. Très bien. Thank you very much for this huge honor, Professor Chang, to be here in Montreal and to present to many friends and many new friends. Many of us have been doing this for a very long time, which is really why I'm so grateful for this talk, because hopefully what I can do today is show where at least one product is in terms of its trajectory, hopefully getting it to its final orbit, if you will, but allowing for many other products at the same time to be able to come up, because without having one already there, it's going to be almost impossible to sort of get others. And we see this with new drug development all the time. And so I really feel strongly that if we can get something there, at least in a very small niche, we'll be all further ahead, as will our patients. So having said that, as Dr. Chang so kindly said, I am an unpaid consultant for a number of companies currently, and delighted to do that, really to try to help all of them grow and get there. And he mentioned also that I've been an investigator in those trials. I would like to acknowledge a number of folks to help put this together, as well as have worked with me in the recent past. Dr. Levien for his presentation at the Joint Program Committee 6 Combat Casualty Care Research Program. Many of us were there in Fort Detrick this past February. Also, the article that I am referring to is listed there that was published in Transfusion. A lot of what I'm going to say, at least at the beginning, came from that article, and I refer you to that. I am not presenting original data here. It's all been presented. Now, just to start, about a week and a half ago or 2 weeks ago, some very important articles, Harvey Klein and Paul Ness came out with in the New England Journal. I'll show you both of those. One of them is really, and I'm not going to go over these, but just to show you how timely all of what we're doing here is today. These came out in New England Journal a couple of weeks ago, and I will show a table, actually. This is the second one, actually talking about the crisis and the sustainability. Sorry, it's a small, but I'm pointing it out just to show you that this is really a couple of weeks ago with, again, with Harvey Klein, looking at how fragile and fragmented our blood system is, at least in the United States. I think in Canada you're much further ahead than we are after some very big challenges that you had many years ago. It's a much more organized and consistent system. In fact, I was just at a meeting with colleagues where we were looking at the blood availability during the most recent hurricanes we had in the States, as well as the fires out in California, to understand whether or not we learned anything from the first disaster, which was Katrina about 10 or 12 years ago, where someone forgot to bring the blood. All the patients got out, but all the blood spoiled. The refrigerators didn't work because the power went out, and they lost thousands upon thousands of units of red blood cells. And it's unthinkable that there was no process. I think we learned some things. We're going to study that and see how we can do better. But anyway, these are coming out. This is a table that I think is very interesting that was just in the first article that I referenced. It looks at the infectious and non-infectious adverse events of red cell transfusions compared to other unrelated risks. And this is, again, public domain, but I think to look at TACO and allergic reaction and trally being more risky, if you will, than even a motor vehicle death from a car accident. Unfortunately, medical errors is quite high, and the Institute of Medicine, at least in the United States, and I'm sure similar groups in Canada have done the same, to point out that many, many deaths are preventable. I'm with a group that is now trying to have 0 preventable deaths by 2020. It's more of a machine looking at having all the monitors that we use to monitor patients combine their information so that we can get not just one alarm here, one alarm here, one alarm here. Those of you that are anesthesiologists or nurses or others know that we just are overwhelmed with alarms, having them all unified so that we have some kind of ability to come up with a problem before it turns into a life-threatening problem, so we can actually have an effect that's not an adverse effect and don't have a statistic that's as terrible as that. Anyway, the infectious diseases and all that, but airplane crashes is way down there, so I guess I'm glad I didn't drive up here. Anyway, another article that I'll discuss in a little more detail at the end just came out in Transfusion. When the slides were being made, actually, it was still in press, but I just wanted to show you that. But thankfully, there are major journals that are now beginning to take our work and publish it and show how important this is. This is 3 cases of critically ill patients with sickle cell and their stories. So again, we'll get to that in a minute. But let's talk about why Dr. Chang invited me here, and that was to look at the product, the HBOC 201. Remember that the new government in South Africa came in 1994 and ended apartheid, which was obviously horrible, and I believe the product was approved in 2001. I saw Dr. Chang had 2002, so I'm sorry if I'm off by a year, but nonetheless, almost 20 years. This was related really in South Africa due to the fact that they had a huge HIV epidemic. Their blood supply was tainted. Blood availability, especially in very rural areas, was very limited. And there was an extremely high hemorrhagic perinatal mortality in rural areas. That's still the case, not necessarily in South Africa, but mostly in sub-Saharan Africa. I believe that the statistic currently is that 5 million people a year die from hemorrhagic shock in the world each year. It's an unbelievable number when you think about that, because there is no blood available for these poor patients and there's no way to treat them in a remote location. So what we're talking about here is really, really important. This is not minimal. Anyway, the product was approved based on a restricted approval, largely based on a study done in South Africa, the HEME 114. I believe Dr. McKenzie will talk about that and the other trials in a little bit more detail. In total, 80 patients were involved in the restricted registration. Then about 250 patients were entered, and the full registration and the product was promoted. Then the commercial use happened first with about 250 patients that received the product, and then a total of 602 were treated with the product once it was approved. Not a huge number. It was limited by product availability. The company struggled to actually be producing. But here are some of the numbers. About 2.5 units per patient of the product were infused. About 1,500 units total were administered. And the range of units per patient was anywhere between 1 and 19. So you really had a huge, average units was 5.7, and the range. But of these, an interesting thing to note is that about 80 of the 206 were using this product when blood was not an option. In other words, blood was not available to treat someone, and this was ending up being a life-saving therapy for a short term, almost like a bridge to get someone to a more high level of care, such as a local clinic where blood potentially could be drawn, cross-match typed, and so forth. So not as a replacement for, but certainly as a bridge. The initial guidelines that came out with the product were to use the product instead of red cells in acute surgical anemia. You'll see how this morphed over time. Standard transfusion trigger was 9. That's a little high by most standards, but realize that much of South Africa is above a mile high, and so that the hemoglobins tend to run higher. The second unit was to be administered if the native hemoglobin fell below 8 grams per deciliter. They were going to treat symptomatic anemia, not hypovolemia. Those of you that are clinicians here know how very difficult that distinction is and almost impossible in acute circumstances to differentiate the two. I've been trying for 30 years to try to sort that one out and try to give people tools to be able to do that. I hope I can be here one day and tell you that I've succeeded. Administer the HBOC to treat signs and symptoms of anemia. Use a very slow infusion rate, 2 to 10 ml per minute, to minimize an increase in blood pressure, which does occur. I'll show you that later. And a maximum of 7 bags, and this was a label. After the launch, there was more research and development and continued commercial use, and this was supported by worldwide compassionate and extended use programs, and multiple case studies have been published. Completed and published the 114 study. Again, Dr. McKenzie will address that, as well as the 115 study, which was the largest study with this particular product that's mentioned here, and Dr. McKenzie was very involved in that as well, so there have been multiple other publications. I'll spend a little time at the end. But what did we learn from this first sort of experience of the largest use of an oxygen therapeutic in patients? Well, it is a circulatory volume expander. You want to avoid prior administration of asanguinous fluids because the patients will definitely get overloaded, volume overloaded. Avoid hypervolemia as with any volume expander, and realize again that this has a high colloid oncotic pressure so that it tends to bring extravascular volume intravascular. Treat hypervolemia as conventional with diuretics. This was under-recognized for sure, not only in this, but also in the big study that we did. You want to use the HBOC 201 in this case as a bridge, as I mentioned, where you basically rely on conventional transfusion triggers to initiate the infusion, use the hematocrit in clinical signs and symptoms of anemia, and continue the administration until the hematocrit is restored, either via erythropoiesis, which can be stimulated by products like this as a hematinic effect, or RBC infusion when they're available. Redose is needed to maintain your target hemoglobin. Remember that the half-life is rather short compared to red cells, and manage the side effect profile without discontinuing the product in most cases. Treat increases of BP or dysphagia in awake patients with calcium channel blockers or nitroglycerin, or slowing the infusion if necessary. We did see some of that, not the dysphagia, but the increases in blood pressure, and it was easily treated, as I say, with a calcium channel blocker. And treat methemoglobin with vitamin C, which can occur, and that reduces it, as long as there are red cells around, so that the enzymes needed to reduce that are available from red cells. In an asanguinous patient, that wouldn't work. But that's obviously not the case. There are always going to be red cells around unless someone basically has no circulating red cells, very rare. Anyway, so the paradigm shift in clinical indication was really when red cells are not an option or available. What we did is look at the efficacy to increase and sustain the total hemoglobin, and that this was not as valuable as you see here as red cells, because red cells, if you have a pack of red cells, there's 24 grams per deciliter of hemoglobin. Here you only have 13. Shorter half-life, 19 hours versus the 30 days that I mentioned. And you're using the efficacy to increase and sustain the total hemoglobin. Obviously, it's greater than hemoglobin-free solutions, and it has a longer half-life than any other IV fluid other than blood, which are typically 3 to 8 hours. That may even be a little bit high. Looking at the side effect profile, and I stress the word side effect, and I don't call these toxicities. Any drug, if you look at least in the United States, probably here in Canada as well, when there's an advertisement for a drug, there's a long list of side effects. Any drug has side effects, as does this one. This is by no means exempt. But side effects are something that we learn to live with. In medicine, there are side effects from every drug that we do. There are side effects to not giving medications as well. And we have to weigh the risk-benefit ratio, and that's a very important part of what medicine is, at least in terms of pharmacotherapy, and surgery too. and life, I guess, as well. Anyway, but methemoglobinemia, it's a non-toxic situation, and it reduces the O2 carrying capacity in a concentration-dependent manner. Again, it's treated with ascorbic acid. Jaundice appearance due to the breakdown of hemoglobin, low oxygen saturation readings, especially on some of the older saturation monitors, a slight to moderate increase in blood pressure, slight decrease or decrease in cardiac output. I'll show you some newer data on that really begins to show that that is not an issue, especially in terms of perfusion and oxygenation and blood flow in vital organs. Increase in liver enzymes, abdominal pain, dilutional coagulopathy, as with any fluid, and some dysphagia. Looking here, I just wanted to mention the product. I unfortunately, is this a... sorry, on the top there, the 13 corresponds to 13 grams per deciliter. The P50 is 40. It's stable for 3 years at room temperature. Its half-life is between 19 and 24 hours. There have been 22 published studies on the product and about 1,700 patients in total, and more than 200 articles on it. So it has the highest hemoglobin content of HbOCs that we've been looking at. Average molecular weight is listed. It's isooncotic. The O2 affinity is unaffected by 2,3-GPG because bovine hemoglobin uses chloride as its offloader, which is commonly present. It is a little bit right-shifted, P50, 40 versus red cells. It's stable for 3 years at 30 degrees, 18 months at 42, which is quite hot. So even in desert situations and so forth, there might be value. Sterile, universally acceptable, and in vivo half-life, as I've mentioned, and it's ready for immediate use out of the bag. So let's transition a little bit and talk about are HbOCs characterized by cardiovascular toxicity? Because this is something that came out in the Nathanson article, that all of them are toxic. And I think that was very, very hurtful to our area, because all of us as investigators, as researchers, as clinicians, as regulators, were sort of fighting this toxicity battle. So let's try to understand, is this toxic in the cardiovascular system, which is exactly where it was mentioned 10 years ago in the Nathanson article that all the products were. Well, this is a study from about 10 years ago looking at maintenance of vital organ perfusion. It's a swine model of, the reference is down there from Journal of Trauma, swine model of exchange hemodilution going from 10 to 30 to 50% in 3 stages. And the organ flow is measured by the microbeads, as you can see. And it's quite clear here that HESPAN, HSA, was really not good, whereas you can maintain organ perfusion very, very nicely as compared to time control, so that the actual product is maintaining organ perfusion. How about oxygenation? From an article in Shock looking at similar kind of model exchange transfusion in swine, going 10, 30, 50, and here it's actually looking with oxygenation using EPR imaging and looking at brain, heart, and kidney, and showing, again, that you're able to maintain, even at 50% exchange transfusion, oxygenation of vital organs. This is critical. This is counterintuitive to the fact that it may increase blood pressure, and therefore is there vasoconstriction, and that was really the big concern. Let's look at cardiovascular safety. Human studies, okay, I'll show you the reference in a minute. This is called the CORE-1 study. Protocol in coronary artery disease, patients undergoing PCIs. Safety and tolerability in patients with coronary disease, so someone who actually is having stable angina and acute coronary syndrome, undergoing percutaneous catheterizations and dilations and interventions, looking at 45 subjects, 3 arms, they're mentioned here, and 2 different treatments, a lower and a higher treatment of HbOC 201 versus the control, and equivalent volume of artificial colloid, in this case was infused over 30 minutes. Now, the blood pressure does go up some, and it is a statistical difference. But the important thing is that the coronary flow, is not changing, and nor is the coronary diameter. Even though the arterial pressure is going up, there is not vasoconstriction in the coronaries, which is crucial, because otherwise you're not going to deliver blood flow, as Dr. Chang mentioned before, in trying to deliver oxygen to stenotic arteries. Hopefully not mine, but I'm sure will happen. Anyway, here's the protocol and the reference. It's from Eurointervention from about 10 years ago, the CORE 2 study, looking at intracoronary infusion of oxygenated product. So you oxygenate it just before you infuse it, and here you can see the protocol and the randomization and so forth was very well done. Again, this is in patients and published about 10 years ago. Looking at that study in a little bit, in these studies a little bit more detail, you have conscious, mildly sedated patients. They're instrumented, measuring blood pressure, LV function based on pressure volume loops, intercoronary and 12 lead EKG, balloon catheterization, and you occlude the coronary artery. This is actually in volunteers. Can you imagine? You occlude the coronary artery and you infuse this product oxygenated. That's pretty gutsy, actually, but here's what you see. In baseline, with the occlusion, you obviously will see decreased ventricular function, and you'll see the flow volume loop, or the flow pressure loop, rather, go up and to the right. Whereas on the other hand, with the occlusion, when you infuse the oxygenated HBOC, it stays exactly the same. This is very compelling information that this product, at least, is not cardiotoxic. And to be saying over and over that it's cardiotoxic when you have studies like this really doesn't make any sense. So are HBOCs characterized by this? Well, you can administer it and there will be a transient increase in blood pressure. If there are larger increases, again, you treat it with calcium channel blockers, nitroglycerin. Vital organ perfusion is maintained despite elevated blood pressure. It's well tolerated in patients with coronary artery disease. There's no increase in coronary vascular tone, no decrease in coronary diameter. Blood flow is maintained, and cardiac work versus the increase in Voluvin controls, which have a 16% increase. I don't know if I showed that one. No, sorry. And intracoronary oxygenated product distal to the perfusion in swine models and human models supports systolic and diastolic function, prevents ischemia and arrhythmia, and prevents increases in biomarkers of hypoxia and prevents angina. So not only is the product not cardiotoxic, but it can be used to treat severe and urgent cardiac issues. And this is really the approach that's been taken over the last 10 years to document that this toxicity really is a misnomer. And so what are the treatments under indication now? When blood really is, a treatment of anemia when blood is not an option. When you can't get cross-matched units, it's medically inappropriate in Jehovah's Witness and other patients, or refused by the patient. It's really an ideal situation for military far-forward deployments and remote civilian casualties, mass casualty events, such as I was talking about, and it can meet the O2 needs of severe anemia for about 7 days, and clinically proven, as I've shown you, to be this oxygen bridge until blood is available or erythropoiesis occurs and the crit goes up. Indications under development, this is really exciting. Dr. Fontes, I don't think he's here, and he and I also collaborated and early on and published this a couple of years ago, where basically liver preservation solution was made with an HBOC, and then machine perfusion and newly developed cell-free oxygen carrier solution under subnormothermic conditions. And looking at the machine perfusion, you see that the organ is actually maintained much better. In fact, there was a press release that came out about a month ago from the Netherlands that a rejected organ was made suitable for transplantation using product. Now, there are a number of others who are working in this area, and this may be that niche that I was talking about, that we can really say, look, we have things that are going to help immediately resuscitate an organ that couldn't otherwise be used, that would be thrown in the garbage. I mean, this is a travesty. Someone donates an organ, it's hard enough to get donated organs, and then the surgeons can't use it, it's horrible for the patient. The patients may not survive till the next organ's available. Here you may be able, and again, a number of folks are working, and this may be the niche that we need to understand. And is it dangerous cardiotoxic-wise? No, we've just, at least in this case, shown that it's not. So very impressive. Compassionate use, looking at critically ill patients in sickle cell. That was the study that I showed you before. It has now been published in Transfusion. Very low hemoglobins, 3.8, multi-organ failure. The treatments were between 6 and 27 units. Enormous amount of hemoglobin was given. In one case, almost 900 grams. They survived to hospital discharge. This is huge. These patients likely would not have survived. Hemoglobin-based oxygen carrier and transplant for life-threatening anemia, going down to 2. In fact, some cases are already coming out where patients are surviving with the organs having been perfused. And again, these are now being published. There's also some new work that I'll show you in a second, but I think I went over this fairly well. I think that this product has really gone past that quote-unquote toxicity and is to a stage now where we consider issues side effects, but certainly cardiac toxicity is not one of them, given that it can be used in patients with severe coronary syndromes, and when you occlude coronary arteries and infuse an oxygenated form of this product, they immediately, and that's in human volunteers, so now that brings us to now what? Thankfully, my assistant was able to come up with that emoji because I don't do emojis, but probably should. But sort of thinking forward, how do we move forward? And I think we're really at a crossroads. All of us here have been working, many of us up to 30 years or more, and it would be really a travesty for us not to be able to get something approved in the very near future. We have to do that so that at least we have something that we can aim towards and perhaps improve upon. But if we don't have anything there, it's like shooting in the dark. You don't know where you're shooting. You don't know if you're hitting anything. Maybe that's a bad analogy, but the point is you need to have something to work towards. And right now, it's very difficult. So here are my thoughts. And again, these are my thoughts. This is sort of me speaking, and if you disagree, please don't hesitate to share. I don't know if this is the appropriate opportunity, but we have to collaborate. We have to work together, even from the industry side, because if we don't, what we're going to find is that we'll have everyone trying to do the same thing, but with no crosstalk and no. Now, obviously, companies have confidentiality agreements. Obviously, companies have their own proprietary information, and I understand that. I do too, for companies that I own. But I understand how important it is that there be this kind of crosstalk, and perhaps this meeting can serve as an ideal venue for that. We must get a product approved as soon as possible for the niche indication. I think we're aiming towards those. We can begin to see what they are, and I hope that regulatory agencies will understand how important it is, at least for those niches, to get product there. That way we have something to work towards. Product will then be a gold standard against which others are compared. And without one product approved in over 30 years of development, and of course it's more than that, but for the more recent ones, it's difficult, if not impossible, to get funding. If a product gets approved, and I'm talking about venture capital funding all the way to NIH funding and Canadian and other other funding agencies, because if we have one, it will allow for funding to happen more frequently. We have to get the word toxicity out of our lexicon, and we have to get the word side effects in our vernacular. So with that, I say merci beaucoup. Thank you very much, and I appreciate the opportunity. Thank you.
Thank you, Jonathan. I must emphasize on what you just say. I think we really have to learn from the parts, both us, quality agency, and the FDA and health agency, and also to concentrate, as you say, on special area, and not to say that blood substitute is good for everything. I think we learned that lesson. We always learn. It's always good to learn. So I think if we, as you say, concentrate on something, not everything, then it's more possible to do it. And I'm giving a lecture saying that all blood substitution of different type is good for different things. It's not the time for